Thank you. Welcome everyone to the 12th webinar in the Louisiana AAP Pediatric Gumbeaux webinar series. We're going to go ahead and get started. If you haven't yet, go ahead and put where you're based in the chat so that we can get to know you as you come in. We'll get started with a little bit of housekeeping. In order to be more accessible, we have enabled closed captioning for this webinar. You can look at the Zoom toolbar to turn on closed captioning in your view. You may need to click the 3 dots that say More to see the closed captioning option. As you can see on the screen, Dr. Gautreaux has no relevant financial relationships, and all relevant financial relationships for anyone involved in the planning of this activity have been mitigated. Without further ado, I will introduce our presenter today. Dr. Jessica Gautreaux is an associate professor of neurology at LSU HSC New Orleans and the director of the headache clinic at the Children's Hospital in New Orleans. She is an active member and fellow of both the American Academy of Neurology and the American Headache Society, and is board certified by the American Board of Psychiatry and Neurology in Child Neurology and in Headache Medicine by the United Council of Neurological Subspecialties. She completed her medical education and residency with LSU. And now I will pass control over to Dr. Gautreaux to begin the presentation today.
Thank you so much. Just 1 second and I'll take over. All right. Okay. So first off, I want to thank everybody for having us to present to the chapter and to participate in this webinar. Today, I'm speaking on behalf of a program that is the American Headache Society's sponsored program for improving care of migraine in primary care. And this is for adults, women, everybody. There's lots of different components to this comprehensive primary care education program that delves into all kinds of different specialty areas. And this specifically is our pediatrics focused topic. I want to let everyone know, and I'll put a QR code at the end, that the grand rounds or these presentations are kind of the hallmark of this program, but there's much more to it. There's a website with tons more content for all different types of learning styles. There's podcasts, there's flowcharts, there's quick guides and references. And then these talks are also recorded and kind of live there in evergreen content as well. So you can always revisit the slides by revisiting the recording. And the recording is myself and another presenter. So will be very similar to what you heard today. We do receive honoraria for doing these teaching programs and the composition of these educational materials, and for travel when we have to travel to present them. For some background, this project was created with grant funding, and we're in the process of trying to get new grant funding for it, but is not currently grant funded. Our goals for today are to talk about how to identify migraine and understand what it means for those who live with the disease, specifically children and adolescents. We will take you through the idea of differentiating primary versus secondary headaches. We tend to take care of the primary headache disorders, but for those of you who are encountering this on the front line, you guys are the ones who really have to delve into deciding when something's an emergency and when something's a secondary headache that you have to address. We're going to talk a little bit about where imaging comes in and the role of imaging and when to refer, though that's a small portion of this. And then obviously at the end, we'll talk about a treatment plan. Our talk today is divided into sort of 2 parts. And I know when you're talking about something as common as headache, especially when you want to build up your toolbox, really the idea is you want to get to the part of the talk where we're like, what do we do? What do we do for this? What can we do for these patients? But I want to reassure you that the beginning of this talk is really my favorite part, because I find specifically for people who live with headache diseases that it's understanding the disease, progressing in your own knowledge of the disease, having confidence to explain the disease to patients is really part of what we do. Just like many other diseases, we have evidence in migraine that just education about the disease with no other intervention improves lots of different outcome measures. And I find for headache, when someone has a new headache, especially a child, most people are concerned that there's something scary. That's the first thing, that's the thing that's keeping them up at night. And so people want to understand the cause of the headaches. And if people don't, parents and kids themselves, teenagers themselves, don't feel confident that the person taking care of them understands the disease and knows what's causing the headaches, they don't even move into the treatment plan. They still continue on this exhaustive search to understand the cause of the headaches. They will do elimination diets and all these different things trying to figure out what's causing the headaches. But if you can help them understand their disease and then thereby understand why you're doing the things you're doing in your treatment plan, I think it really helps move things along and help us with adherence and with better outcomes for patients. So that's where we'll start today. So first, what is migraine? It's so important for patients and for everyone who really encounters people who live with migraine to understand that migraine is a neurological disease or disorder that does occur as attacks of head pain, but is just as typified by many other symptoms. You have nausea, you have the sensory disturbances, you have cognitive disturbances, you can have vestibular disturbances. So there can be lots of other complaints that accompany the attack of head pain. All of those parts of migraine are just as much a part of the disease as the headache itself. The other thing that people have to understand is that this is an inherited disease. It's part of the way they're made. It runs in families. Yes, someone has to be first, but usually it's in families. It's important for them to understand that the disease can look different in different members of the same family, and also that not every member of the same family has to be affected. But this is a very basic concept that people have to understand to know that you know the cause. The cause is basically your genetic makeup, that you have these attacks similar to other attack-based diseases like asthma. For migraine, we know that there are actually multiple different phases that compromise an attack. So it's important when you think about migraine that you think about migraine disease, which is sort of the state of living with a tendency to migraine attacks that last your whole life. And then we have the individual attacks, what makes up the individual attacks or the symptomatic period. So we classically think of a migraine attack as that time when someone has the unilateral throbbing head pain with associated symptoms, but we're understanding more and more about this disease and recognizing that there are brain changes that are happening long before the patient is in the pain phase, and these can happen hours to days before the actual attack. These symptoms, the patients can actually have symptoms when they're in this premonitory phase of brain changes, and it ranges and is different in each patient. Things that have been reported are things like fatigue, mood changes, certain food cravings, increased yawning, change in urination pattern, even in other bathroom habits, neck stiffness. So there's a variety of things that have been reported. For patients who do have an aura, which is about a third of people who live with migraine disease, the aura kind of starts typically before the head pain, though can overlap with the head pain. And this is where you have that 5 to 60 minutes of a reversible neurological symptom, most commonly visual in peds. And then obviously the advent of your head pain phase. Again, it's a throbbing pain that lasts 2 to 72 hours with associated symptoms, light, sound, smell, mood changes, difficulty focusing, decreased function, lots of different things during the head pain attack. And then we also understand now that there's probably a recovery period after a migraine or a postdrome. So people will describe that their head still feels sore. That's very common. They may feel fatigued or wiped out. They may have cognitive slowing or fogginess, maybe some musculoskeletal stiffness. And then some people will also report things like euphoria after. It's important to recognize both ends of symptoms that happen around the headache phase, because those things may also cause patients interference with their productivity, their quality of life, and might be things that you have to think about in a treatment plan for these patients. The other place that recognizing the prodrome and the postdrome are important is it's helping us to learn more and more about the brain physiology of migraine and understand where things are really happening that make up migraine disease at the level of the brain. The part of migraine that we do understand very well, at least, is the pain phase. The symptoms from the premonitory phase are pointing more and more towards probably the hypothalamus as a migraine generator, but once the migraine changes have started, the piece that we've really broken down and understand is where the pain is coming from. And I think this is sort of helpful to know a little bit about and remember and be able to tell patients. So I always tell them that the pain is coming from the big nerves in their face. So we know that the trigeminal nerve gets activated, causes changes out at the vessels of the dura and of the meninges, and then that gets reflected back and then up centrally to where those pain signals get processed at the cortex. What's interesting is that those trigeminal fibers are coming in and synapsing in the level of the cervical spine. And so I just yesterday pulled this diagram up because someone was asking me, should they be concerned that now their migraines had neck pain? And so knowing that the pain signals are coming in, synapsing in the cervical spine where other inputs are coming in from the back and the neck, it explains why the pain from a migraine isn't just limited into the classic kind of trigeminal nerve in the front of the head, but can migrate into other places of the head as well. A little bit of background on stats. So a lot of people who come to clinic will tell you they didn't know kids could have migraine, or they are not sure it's migraine because they thought that was an adult disease. So it's really nice to be able to share numbers with them. So migraine affects about 1 billion people worldwide, far more common in women than men in adults, but when you're children, that's not the same, which we'll talk about in a few minutes. Migraine affects probably 1 in 11 children where it's recognized and it's diagnosed. And in our country, we're somewhere around probably about greater than 40 million Americans who are living with migraine disease. It's a lifelong disease. And when you diagnose a patient with migraine in your pediatric clinic, it does behoove of you to spend the time to talk to them about this disease because this is something that they will live with throughout life. But I think even more interesting is we recognize that there are syndromes that precede kind of what we think of as typical migraine that are related or markers of migraine. So it truly is a lifelong disease. And then even more so, there's mounting evidence that potentially infantile colic is related to migraine. There's a very significant increase in the prevalence of migraine in mothers and fathers of children who have episodes or who have colic. And I think over time, trying to understand that and really put that together would be interesting because a lot of the things we do for colic would drive someone in a migraine up the wall. It would be miserable. So if colic really is a migraine variant, then it may be time to rethink the way we help babies who have colic. But nonetheless, truly mounting evidence over time that migraine, the genetics of migraine manifest throughout your lifetime. As I mentioned, it's more common in females than males, but that doesn't really happen until you're post-pubertal. When you are young, migraine is just as common in boys as it is in girls. And actually, boys will present with migraine just slightly younger than females will start to have their migraine attacks. Something else that I think is really relevant for people in primary care is to recognize just how common migraine is in relation to the other childhood diseases that are considered to be common childhood illnesses. So migraine has very similar prevalence to ADHD at 9.1 versus 9.8 for ADHD, and it is more common than asthma, hay fever, and ear infections, things that are commonly tackled in the primary care office, at least for initial management. Things to know about your patients who live with migraine. We know that migraine is the second leading cause of years lived with disability when you look at the global burden of disability study from several years ago. When you look at kind of people who are in midlife, that most productive period of life, it's actually the cause or the highest cause of years lived with disability and decreased productivity. So what does that mean? Well, kids' productivity is attending school and participating in social events and sporting events and their extracurriculars. And so what you see in patients who have migraine, they have much higher rates of poor attendance for school, much higher rates of school-reported problems, and a higher rate even of having to repeat a grade than age-related peers without migraine disease. So moving on to how you differentiate migraine or a primary headache disorder from the other headache disorders is where we'll kind of move next. So the primary headache disorders are defined by criteria. That is how we diagnose them. So I always tell people about the international criteria for headache disorders and let them know that this is a global set of criteria. So they can go anywhere in the world and they have the same disease. and that this is the test. There is no blood test or imaging test or anything that will diagnose the primary headache disorders. It is these criteria that are universal that help us label which of the primary headache disorders they have. Most of you are probably familiar with the classic criteria for migraine, but there are a couple of nuances that can be, or a couple of nuances that are specific to peds. So the duration of a migraine attack can be shorter in children, so it can be down to 2 hours instead of having to be the classic 4 hours. You can also count in the period of time that children are sleeping as part of their migraine attack. So they may be awake for 30 minutes complaining of head pain, but if they sleep for 4 hours, then that counts as the duration of their attack. Head pain in peds can be unilateral, like the classic idea of migraine, but it's often bilateral in peds, actually more common to be bilateral probably in pediatrics. And then the last one is that since kids can't always tell you that they are light or sound sensitive, you can infer the associated symptoms of photophobia or phonophobia from behavior. So if they are avoidant of their tablets and TVs and want to lay in a quiet, dark room, without saying that the light bothers their eyes or the sound bothers their eyes, you can infer that from behavior. As I mentioned, about 30% of people will get a warning that they have a migraine, and there's a video playing here that will show you what a typical visual aura looks like as it progresses. If you've never had an aura, this is, I think, a really cool video that lets you know what people experience. Aura, as you typically think about it, starts before the head pain phase, but for some people, it's almost simultaneous, and that's okay too. It should end before the migraine is over. Again, in kids, visual is going to be the most common, though some kids do have some of the other aura symptoms. And one thing that kids say all the time is that they feel like their vision is blurry during a migraine. That is not an aura. It doesn't count as aura. A lot of people in a migraine feel they have difficulty focusing just from everything that's going on as part of a migraine attack. That is not this, like you see on the screen, that's a clear focal deficit spreading across the occipital cortex, as opposed to just this generalized blurring of the visual field, which is probably just difficulty processing and focusing. So when taking a headache history, we like to think about dividing that, taking a good thorough headache history to identify things that would make us more concerned that there might be a secondary cause of headaches. And when I say secondary, that doesn't necessarily mean an emergency. It just means that this headache may be explained by something else and isn't a primary headache disorder, which by definition means the disease state itself is causing the headaches. There have been some mnemonics that have been validated over time for use as a red flag mnemonic, and Snoopy is the one that has been validated for kids. The S in Snoopy, or S's, stand for systemic symptoms or secondary risk factors. So these are going to be other things happening in the patient at the same time as the development of the onset of the headaches, like fever, weight change, or other disease states or comorbidities that put them at increased risk of having a secondary headache disorder like immune suppression or cancer. Any kind of neurologic finding is considered a red flag, and that does count papilledema. So sometimes people forget that the fundoscopic exam and papilledema is a neurologic sign, but any kind of abnormality on your neuroexam or papilledema is considered a red flag. For O, onset is a sudden or thunderclap headache. We think of that as that 0 to 10 and under 60 seconds type of headache, worst headache of your life. Patients who are older that have a new headache onset over age 50, that's considered to be a red flag. And then pattern change. So people who have an existing primary headache disorder and then suddenly have a change in their headache disorder with new symptoms or a significant change in their disease frequency or something else about their disease, that should be a red flag. And then any precipitants. Position change, certain activities, Valsalva. And then we used to say that young age, that was the Y on Snoopy, but there's debate about what that age should be. Some people feel age younger than 5, some people feel age younger than 6 is where you need to consider secondary headache or imaging. But I would say around 5 or 6, depending on your comfort level, you may consider it a red flag. It is not that those patients have an increased risk of secondary headaches because of their age, or that population has an increased risk. It's because people tend to feel less comfortable with their ability to describe what's happening to them. That just raises caution a little bit, because you may not be getting the full story. You can also think of those Snoop qualifiers as being broken into red or yellow flags, meaning those things where you feel like you need to get the patient to an ER as they're telling you about it, versus those things where you probably have some time, you could schedule the outpatient MRI versus needing to send them to the ER right away. So your ER red flags are going to be obviously that thunderclap, worst headache ever, new onset intractable vomiting, especially with position change like waking up, abnormal findings on neuro exam typically are ER in kids because of the delay in getting things like sedated imaging. So if you're going to need emergent imaging, you're going to probably have to do that through an emergency room. And then obviously any other provider concerns, fever, headache, and someone who doesn't have headache, rule out meningitis, those things are possibly ER. Your yellow flags are going to be some of those things where you want to keep looking, but you probably have more time. So a gradual change in headache pattern that's not sudden like a thunderclap. Those younger patients, you probably have a little bit of time. It doesn't have to be an ER visit to get imaging. Side block headaches, some of your triggered headaches from your movements, those things you probably have a little bit of time and don't have to do your workup right through the emergency room. We talk often about using the pattern of the headaches to help you classify which headaches are concerning and which headaches are not concerning. So reassuring patterns of headache for primary headache disorders or non-concerning headaches are going to be acute recurrent headaches where patients have repeated episodes of stereotyped attacks, or headaches that come on and really do not progress over time. So they might have a lot of headache days, but the overall picture of that headache is not changing over time. It's staying pretty stagnant with no progression in frequency, intensity, or associated symptoms. Your more worrisome patterns where you would want to consider more secondary headache would be things like chronic progressive headaches, where someone has onset of high frequency headaches and it's just getting worse and worse over time. That acute thunderclap, which I already mentioned. Headaches that are daily from the start. So that's a pattern called new daily persistent headache. It's very common. Probably most common period for NDPH to start is in adolescence and the teenage years. And that does require imaging as a rule out, though most often in our age group, it is just new daily persistent headache. And then that change in pattern. So people who've had a long-standing headache disorder where it was acute recurrent, and now it's had a sudden change, those are more worrisome patterns for secondary headache. So the biggest question that probably comes up is when to image and when not to image. And so there are obviously arguments to image kids who have headaches, and there are arguments against imaging kids who have headaches. The people who are recommending imaging are people who are concerned for brain tumors, and that's not unreasonable. Brain tumors are the second most common childhood malignancy. It does have a relatively common incidence. And there are small case reports that have shown series of patients where headache was the only symptom of a brain tumor. On the flip side, arguments against are things like repeated CTs may not be the best studies and also expose children at a young age to recurrent bouts of radiation. MRIs are costly and for our younger patients require sedation and the risk that is with that. But probably the most useful numbers that have come in imaging and headaches is a study that took a group of children who had headache with normal neuro exams and imaged them, and then compared it with other population studies of healthy children or controlled children who had brain imaging. And what they found was that the rate of a finding was about 2%, 2 to 2.5% in both groups. So kids with just headache had the exact same amount of findings as those kids who had never had a headache. So normal brains had just as many findings on MRI across the board as kids who had headache with a normal exam. If you have an abnormal neuro exam, that rate goes up, where you end up having about 2% of people actually having an abnormality that requires an intervention. So there's a real separation from incidental findings to kids who have an abnormal neuro exam having things that need to be intervened upon. So kind of the hallmark is that you need to do neuroimaging in anyone who has headache and an abnormal neuro exam. The American Headache Society has stated that you do not need to image people who have headaches consistent with migraine and a normal exam, no red flags. The Choosing Wisely campaign has echoed that, saying not to do neuroimaging in patients who have headaches that meet criteria for migraine. And if you're going to image someone for a headache, you really should try to do an MRI unless it's an emergency situation where you're worried about something like a thunderclap or you're getting a CT to rule out blood. And then finally, the last QR code, the American College of Radiology has a whole website that is the appropriateness criteria for imaging and headache, where they take you through some very specific scenarios, some really unique and very detailed scenarios to help you think through if you need if you need imaging or not. And so you can follow all of these different tools that'll tell you this specific scenario that you just described, image or don't image. And so I find that useful when you really feel kind of lost if you need to do it or not. Okay, so as I mentioned, now we're going to kind of move into the what to do part of migraine care. But again, you're not going to have anyone listening to the point about what to do if they don't really feel that you've explained to them what the cause of their headaches are. And there was a good study from many years ago where they looked at patients and parents who were coming to see their primary care and then separately neurologists for initial visits for headache. And they found that for parents, the things that were highest on their list of what they wanted out of the visit was they wanted to understand the cause and they wanted to know that something serious wasn't going on. Things like medication and imaging were actually far lower down the list than just having an understanding of what was happening. Similarly, patients, the kids themselves reported the same. Number one for them was knowing something serious wasn't happening to them. And then higher than parents, obviously, they wanted something for the pain because they were the ones living it, which makes sense. But even for them, knowing that nothing was seriously wrong superseded treating something as awful as migraine pain. That tells you how important it is to people experiencing such a degree of head pain to really understand that there's nothing wrong. So one of the first things we talk about in migraine management is how to manage the disease as a whole. If you think about the way that we manage chronic diseases or diseases that people live with throughout life, there is typically, yes, components of medication, but also how their overall wellness impacts the disease is taken into consideration as well. And so for migraine, we have identified several kind of everyday factors that seem to influence this disease. And when we talk about influencing migraine disease, what we mean is usually headache control or headache frequency. So there are habits that we can have day to day that can influence our migraine disease. And it's important when you talk to people about that you frame it in the way that I just spoke. If you tell someone that they need to drink more water or they need to change their diet, they may think that you're saying the cause of their headaches is poor water intake or something they're eating. And what you want to make clear is that you recognize that the cause of their headaches is this disease state. And then these are things that may be affecting that disease. And so sometimes I'll compare it to other things and say, if someone who had asthma became a smoker, they might have more trouble with their lungs. Still, part of the cause is their disease of asthma, but it's being exacerbated. I think there are lots of different models of chronic disease where you can find something to compare like that, but it's important that they know that you know the cause is the disease, and these are things that can make it in better control or worse control. The other thing about talking to people about habits that things they can do day to day that will affect their diseases, that especially for children, they need these recommendations to be incredibly specific and defined. You can't tell someone that it's important for them to drink more water if they live with migraine disease and expect them to know how much that is. If they're drinking 1 bottle of water currently and they go home and they drink 2 bottles of water, they will now think they're drinking more water, when that is not the hydration goal for someone who's living with migraine. The other thing about that is that they have to understand that it is a pattern of change over time of these habits that will influence their migraine disease over time. So if you tell them to drink more water and they have a super stellar day, or they drink 5 bottles of water and they get a headache that evening, you will lose your credibility because they got a headache on the day they drank the most water they've had in a week. So they have to understand what we mean by healthy habits and lifestyle change and how that reflects on the disease over time. And the habits that we talk about are the SMART habits. It's an easy mnemonic to remember what to teach patients. Key to managing migraine is sleep. So people who have migraine disease really do have to get enough sleep for their age. And so that will move. That's a moving target based on the age of your patient. They have to have good quality of sleep. So you need to screen for sleep disorders, insomnia, sleep apnea in patients and work on that if those are present in someone who's living with migraine disease. And then finally, they have to have a consistent schedule. So working with them on getting to bed at the same time and waking up as close as they can to their school time, basically 7 days of the week if you can. For meals and hydration, we have moved away from telling people to avoid specific foods or create food diaries. What we really want to focus on is eating 3 meals a day, so avoiding periods of fasting or lots of small meals with snacking if they're people who can't eat or don't want to eat 3 large meals a day. Trying to choose the whole foods, less processed foods tends to be a good recommendation as well. When in regards to water, we lay out very specific hydration goals based on their athletics, timing of athletics, how much water to drink based on their size, and actually give them measurements and give them goals. Drink 4 bottles of water, not just drink more. For activity, we know that when we've studied an hour of exercise 5 days a week in adults who live with migraine, it's shown equivalent efficacy to topiramate for prevention of migraine attacks. And so in kids, we recommend that people start to increase their activity. We aim to try to get at least 30 minutes, 3 to 5 days a week. And a lot of my patients, I try to push them onto that goal of 65 days a week. And that even sits under the AAP's recommendation for activity in most of these kids. Obesity is an independent risk factor for higher frequency migraine attacks. So if you have a patient who's living with both, certainly addressing both is important. The R in SMART is for relaxation. And so there is evidence that mindfulness, relaxation practices, yoga, deep breathing, biofeedback, lots of different forms of relaxation do seem to change outcomes in migraine. There's good grade A evidence for that. We know that that is not accessible to all patients. And so now they have started to study the use of apps and other ways to practice some of these techniques without someone to teach it to you directly, a mental health provider. So I usually tell teenagers, especially who are very tech savvy or very into apps and all, ways to find apps that will help them practice some of these to help. If someone has depression or anxiety or you think needs therapy or stress management, then obviously very reasonable to refer them and address those things as well. And then finally, there's the idea of triggers. So we have started to move away from the idea of people having to live this avoidant life of classic migraine triggers. That actually came from the understanding of the prodrome. We think that things we think used to be triggers or we thought were triggers like chocolate may very well have been cravings because of the changes happening in the brain at the prodrome. So we have sort of backed off of this idea of triggers and we don't give people a list of migraine foods to avoid anymore. But some patients do have very specific identified triggers that they feel they've tracked and noticed over time. And so it is appropriate in those patients to help them think of ways to modify their behavior if they have identified their own unique specific triggers. Just a minute to touch again on the behavioral therapies. There's grade A evidence for those. They're endorsed by multiple guidelines and they tend to have long-lasting benefits for this disease. And this is something that patients can revisit at all different stages of their life without worrying about interaction with other medications, other comorbidities. So that's what makes it one of the great options for managing headache disorders. You can use these alone. You can use them in combination with other therapies. There is the headachereliefguide.com, which is actually a migraine disease website geared towards teenagers. In addition to disease education, there's actual activities there for patients to be able to employ some of this behavioral therapy on the website, in addition to things like calm apps and all of that kind of stuff that are not migraine specific. But Headache Relief Guide is really nice because it's geared toward teenagers. The American Migraine Foundation is an overall patient support for people living with migraine. It is not PED specific, but there is a very nice PED section there. And then there's also a section on the AMF website where patients can find resources for doing some of these relaxation therapies with evidence, again, without a therapist to teach direct to them. So it helps in our shortage of mental health. So next, we're going to talk a little bit about acute therapy for migraine. And so the old model or a common model that used to be used for treating migraines attacks was the idea of step therapy. And so people could employ either within a single migraine attack or over time in migraine disease, multiple attacks, this idea that you first had to try one medicine that wasn't as specific for migraine, and then you could escalate if it didn't work. So When your headache first starts, you need to take an ibuprofen or an NSAID. And then if it's not better, you can add a triptan. Or you need to try ibuprofen for a month or two. And if it doesn't work for any of your migraine attacks, then we'll escalate to a triptan. And then finally, if you're not feeling better, maybe we're going to do a combination of those or add in an antiemetic, a dopaminergic agent. And that has really fallen out of favor for what we call the stratified model of migraine care. So the stratified model of migraine care allows patients to have options for their migraine attacks based on the severity of their symptoms at the time. And this is ideal because the step model, one, makes people suffer unnecessarily. If you tell them they have to try an NSAID first for their most severe migraine attack when we know it's unlikely to work at that point, that's really wasting time. They should be able to go straight to something that might work better. The other thing is, if you're not careful in a stepwise fashion, people will start to think that there's no role anymore at all for NSAIDs, right? They failed it. And you really don't want people who have migraine to feel that their options are limited. You want them to know that NSAIDs are still a tool for them, but that's a proper tool for a milder or a moderate headache, probably a mild headache. And then when they have more severe headaches, they have all these other options. So using a stratified model of care has evidence for improving outcomes and patient satisfaction in migraine care, but it also helps patients continue to have a robust toolbox of things they can do to help in an attack instead of eliminating things over time and limiting them down to only a few options. When we talk about acute treatment options, there are lots of different classes that we use. Most commonly, we're looking at NSAIDs, triptans, and dopamine agonists. So for NSAIDs, the biggest thing is to make sure that you're using the formulation that is most desirable to the patient at the time. Some people don't want to swallow a tablet. They might want a dissolvable when they're in a migraine attack. The other thing is to make sure with NSAIDs that they're dosing appropriately. A lot of people who are treating migraine with NSAIDs are using over-the-counter formulations. Sometimes those bottles don't dose appropriately for weight in our pediatric patients. So helping to guide your patients on how to use those over-the-counter formulations is important. When you look into triptans are serotonin-based drugs that are migraine specific, and we could get into a lot of information on how they work on the migraine pathway, but they work centrally and peripherally to end migraine attacks. They have several that are FDA approved in children. They come in multiple formulations. The triptans allow you to do lots of tailoring and shared decision-making with your patients. How do you want to treat your migraines? Do you want something that works fast? Do you want something that works slower? Do you want something that dissolves? Do you want something you squirt in your nose? So that's the beauty of the triptans, is how much you can tailor them. We do have some evidence that a combination of a triptan with an NSAID is superior, especially in teenagers, than using either agent alone. And so that's the combo you see there of sumatriptan naproxen. Brand name it's sold under is Trexamet. And hard to get in Louisiana, but easier to get for those of you seeing patients over in Mississippi. So great option because it's covered on the Mississippi health plans much better than it is here in Louisiana, and you can get that to patients, and we have great evidence for it. And then finally, there's the use of antiemetics. So remember, in patients who have nausea with their migraine, sometimes you do have to add an agent targeted to the nausea itself. But if you use something that targets dopamine, you will get effect on the migraine too. If you choose something that is treating nausea via some of the other serotonin receptors not involved in migraine, or even histamine and the histaminergic properties, you're not going to get as much migraine action. So try to use your dopamine antagonist when you're going to move into the anti-nausea spectrum. Oops. We would like for people to be comfortable using at least one triptan, especially since we have a triptan, rizatriptan is FDA approved down to 6, and you have several others that are FDA approved over 12. So we have lots of options for triptan use in pediatric patients. And so when you're prescribing triptans, there's the rule of there's a couple of tips that we recommend that you remember kind of in your practice about using triptans. First is to counsel patients on the rule of 2. They can take a second dose after 2 hours if they haven't gotten full benefit or met their treatment goals, but they shouldn't take more than 2 doses in 24 hours. And overall, you want them to take it no more than 2 days a week, or they could get medication overuse or a rebound. If you prescribe triptans, you will at some point get something from a pharmacy or something from insurance, and a patient who takes an SSRI or an SNRI as well for a mental health disorder about the risk of serotonin syndrome. When you look at where the labeling for the risk of serotonin syndrome came from many years ago, those cases have been reviewed, and the patients who were used as the incident cases by today's criteria for serotonin syndrome would not meet criteria for serotonin syndrome. And then since then, they've also done large inventories of patients taking both triptans and an SSRI or SNRI, and have found that the rate of serotonin syndrome is no higher in people taking the combination than in people who just take an SSRI or an SNRI alone for depression or another disorder. And so the AHS no longer supports that there's an increased risk of serotonin syndrome in patients using both. So it's important to tell your patients about that, because they're going to get those warnings at the pharmacy or from their insurance. And so you need to reassure them that this is the current evidence. You should warn people about potential side effects of triptans, because it's a funny feeling they are unlikely to have had before from medication. You can get tightness in your face, your neck, your jaw. They may feel hot or flush for a moment. Some people even feel flu-like symptoms. Some patients don't care about those side effects. It gets rid of their headache, and that's worth it to them. Other kids will avoid taking their triptan or only take it for their worst headaches because they don't like the way it makes them feel. If that's the case, you can usually change to another triptan and not have those side effects in the same person. Only about 1 in 100 people feel those side effects, and it's usually not across all triptans. It's 1 or 2 of the 7. So you can kind of move around in the triptans and alleviate that. And then kids don't have as many of the contraindications as adults do, but it's important not to forget those things like cardiac or cardiovascular disease, history of stroke or cerebrovascular disease, the specific migraine subtypes that are contraindicated, and then some other uncontrolled diseases. So this is just a quick chart that runs through what is FDA approved and not. This is a great chart to keep on hand if you go to the website after this talk and keep the talk available to you. But just looking at this, you can see that rizatriptan is the one that's FDA approved over 6 or 6 and over. And then amitriptan, sumatriptan plus naproxen, zolmitriptan are the ones that have some FDA approval in our population. Everything else is approved 18 and up. You can also see on this chart the different formulations. So you'll remember that I said we have triptans that come in swallow tablets, dissolvable tablets, nasal sprays, injections. So you really can talk to your patients about how they want to treat a migraine, because they're feeling pretty miserable. And you will have patients who tell you, I want a nasal spray, I don't want anything to swallow. Or others will say, I can't put anything in my nose. I have some teenagers who are like, give me the shot, it's fast, and I can go on about my day, or the sub-Q. So you can really tailor it to their own preferences. The other thing to know is that naratriptan and bromotriptan have a longer half-life. They last in the system longer. So if you have patients who tend to have longer migraine attacks or migraine attacks that recur in the same day, you might want to use one of those longer half-life triptans. The other thing about the longer half-life triptans is their onset, their peak onset is slower, and so they tend to have a lower side effect profile. So if you have someone who's sensitive to the triptans, use a longer half-life and a longer to peak formulation, and you might cut down on side effect. Okay. There's also a pediatric migraine action plan that has been developed from a group of headache specialists. This was based off of the asthma action plan as a tool that you could put in schools. The reason for that is that it's familiar to teachers and school nurses because they've seen this same idea for kids who have asthma. It's also a clear kind of visual for the students themselves, this idea of green, yellow, red, and what to do when you get into those areas. And so this is available and downloadable, and something that you can fill out and give to your patients to have at school, where people are kind of familiar with this thought. This is basically that stratified model, but put into a visual that is more common in schools because it's used for other disease states. So when you're trying to treat acutely, a couple of things that can be helpful. If nausea and vomiting is prominent and not solved by one medication, feel free to add an anti-nausea medicine if you need, but for many patients, the triptans take care of all of the symptoms of the migraine attack. If they're vomiting and can't keep medicine down though, try a non-oral route like the sub-Q or the nasal. If NSAIDs are not effective, Again, check that dosing on the bottle, make sure they're taking it at onset. If triptans aren't effective, you can switch amongst all the different triptans. Failure of one triptan does not mean they won't respond to another. Remember, we have that evidence of increased efficacy if you add an NSAID, so you can add an NSAID to a triptan, and then remember you can add a dopamine antagonist as well. If they have recurrent headaches, you can add an NSAID to your triptan, especially an NSAID with a long half-life can be useful, or remember, consider switching to one of those triptans with the longer half-life. For people who are overusing their medications, you may want to talk about migraine prevention, discuss medication overuse headache, make sure they're following those lifestyle habits. And then if they're continuing to fail therapies, obviously you might need to bring in a headache specialist. So now the talk about prevention. And I always like to talk to my patients in the order that we're presenting this. You know, life-based habits are what are going to change your disease over time. Even if we do that, you're still going to have some migraine attacks because we cannot cure the tendency to have migraine attacks. And this is what you're going to do. And this is how we're going to be prepared when an attack does happen. And then I'll say, once we have those first two pieces in place, there may be times where we need to do a layer of a preventive. And so when you're going to add on a preventive, that is a long conversation with families because there's a lot that goes into using migraine prevention in pediatrics. I have found sometimes that people will go to prevention first, thinking, let me just try to prevent the attacks, but that's actually not the way preventives work in migraine. They're really just a little bit of an additive on. So you have to do all the other steps, and then there may be a role for a preventive, but you can't rely on a preventive alone to change this disease. Times when you might want to consider adding a preventive, if they're having a lot of interference with activities or things they want to do, like go to school, play in their extracurriculars. If they have frequent headache days, we usually say definitely more than 2 headache days per week, consider a preventive. When you're getting in that 4 to 6 a month range, many people will consider a preventive, but there's a little bit of gray area there. Sometimes it's just preference. This is a disease that runs in families. So sometimes parents will kind of have their own ideas about how to best manage this disease, and they may have a strong desire for a preventive. And so then that opens up that discussion. And then finally, if you are having a lot of trouble treating individual migraine attacks, even if they're not happening often, it may be worth trying a preventive because there's some evidence that preventives can not only decrease your number of headache days by 50%, but may also improve the response of individual attacks to an acute therapy if you're on a preventive. The classes of medicines that we use for prevention really vary all the way from things such as nutraceuticals and vitamins over to our prescription agents, and then even things like devices, which we'll talk about in a little bit. Most commonly, most of us probably go to nutraceuticals first. They are highly desirable in peds where people tend to have a little bit less comfort with a daily medicine because they have low amount of side effects and they have some evidence. Commonly, we use riboflavin, magnesium, CoQ10, melatonin. If you are going to use a nutraceutical as a preventive, you can't forget to tell them about what to expect. Something like riboflavin discoloring their urine would be alarming if you don't warn them about it. But overall, these are the ones that we use with some specific dosing for peds. You may have heard that Butterbur is a good migraine preventive, and it is very good. But unfortunately, it's not regulated in its production well enough that we feel that it is worth the risk of liver toxicity, so it's no longer recommended. Looking at pharmaceuticals, there's some evidence for topiramate, amitriptyline. Topiramate and amitriptyline have high or moderate confidence, whereas propranolol and valproate have low confidence. And then ciprofloxacin doesn't have a ton of evidence on paper, but everyone uses it clinically, so we usually add it to the list because it's very useful, especially in younger children. Again, listed here with their recommended dosing for peds and the common counseling that you would need to give to families if you were going to start one of these medications. When we choose a medication as a preventive, we often will think about the other things that can happen when you use that medication and how that might be of benefit to the patient. So for example, amitriptyline may make you sleepy at bedtime. Insomnia or difficulty with sleep regulation and sleep hygiene can be really common in people who have migraine. If we can get them sleepier, then they might get benefit for their migraine disease from both the medication and the improved sleep. So that's kind of how we think through choosing preventives. Likewise, you may have a preventive and a comorbidity that makes you want to avoid a certain preventive. So you can use it both ways. You can't talk about migraine prevention in kids without talking about the CHAMP study. So the CHAMP study is a study where they actually did a randomized placebo-controlled trial of amitriptyline and topiramate versus placebo for migraine prevention in kids. Kids who were enrolled did what we already talked about. They were educated about their disease. They were helped with healthy habits. Their acute treatment was improved. And then they met regularly with a nurse to check in, and then they were assigned to one of these groups. And most people know that the CHAMP study was interrupted for futility because everyone, or an equal amount of kids, were getting better. So in CHAMP, about 70% of kids were improving on this regimen of lifestyle change, acute symptomatic improvement or treatment improvement, and then use of a preventive, even the placebo group. The topiramate and amitriptyline group had higher rates of side effects. So what we learned from CHAMP was that this model of acute treatment, lifestyle habits, headache education, and possibly the use of a preventive improves about 70% of kids who have migraine disease. It did alter the rate at which some people use topiramate and amitriptyline, moving people more likely to choose a nutraceutical as a preventive because of the lower rate of side effects, but that's starting to swing back a little bit. Most of us discuss CHAMP in its entirety with families, let people know that there may be placebo effect from the topiramate or amitriptyline, or it may be something medicinal. But after the honest discussion, we usually can have shared decision-making about the best preventive to choose if a preventive is needed. Other tips for using preventives are that you have to set the tone with preventives. So people need to know that the goal of a preventive is only to decrease their attack frequency by 50%. Sometimes you do better than that, but that's how these medicines are studied and come to market, as a decrease of 50%. As a side note, sometimes it improves the response of each individual attack to the acute treatment, but this is not a cure. You also have to warn people that it takes a long time for this effect to happen, at least 2 months on full dose before we will state if it's starting to have an effect or not, and most of us will leave it 3 months to see full effect. If people get a benefit from a preventive, we usually leave it for approximately 3 more months, and then we pull it off. So I tell people from the very beginning, this is not a medicine forever. The idea of a preventive is it comes in, it has an effect at the level of the brain on your tendency to have migraine attacks. And once that's done, we can take this medicine away. And certainly if you have another period of life where your headaches increase again, we could do it again, but you're not meant to live on this forever. So you need to set that stage early on so they're not surprised when you take away the medicine that's been preventing their attacks. And then otherwise, some of these medicines do have side effects. So if you start and titrate, you can avoid some of those side effects. Couple of things to consider. If you're having trouble with treatment, obviously consider referral to a headache specialist. When you're going to do that, things you can tell people to expect are that headache specialists do have access to research studies, procedures like nerve blocks, and Botox to potentially help headaches. We tend to be more comfortable with use of neuromodulation devices and can bring that into their treatment regimen. And then though the new medications targeting CGRP are not available from the FDA in this age group, we tend to have more comfort with those and can navigate using those prior to age 18 if we need to in certain cases. So there are a couple of slides on migraine and contraceptive that I am not going to cover now because it would take the rest of the time, but I will stop now. Again, these talks are available to you all on the AHS website at the First Contact site, so you can go and read those 3 slides on contraceptive. But if I end here, that will give us a chance to be able to open to the floor for questions. This shows you a little bit what the First Contact website looks like and all the things that are available there if you'd like to visit. And I appreciate your time.
Okay, I will go ahead and ask the questions that we had in the chat and then open up for people to unmute. We do have a lot of people on today, so just FYI, if you're unmuting, it might be helpful if you raise your hand and then I can manage that a little bit better. Okay, our first question from Dr. Artigues. Do you recommend using MRI with or without contrast?
So I know from our radiologists, and most people feel that an MRI without will show us most of the things that we're worried about. But certainly if you have suspicion for other things based on what your red flag is, sometimes you might add contrast. But I would say most often people feel pretty comfortable with an MRI without.
Okay. And then next, is there a set time frame for having a new daily persistent headache prior to getting imaging?
So the definition of NDPH is 3 months. That's where you can classify someone as having NDPH by the criteria is 3 months of a daily headache. I would say that most people, depending on other symptoms, are a little more uncomfortable prior to that 3-month mark. So there is no harm in imaging before then, but certainly if someone meets criteria for NDPH, imaging is part of the workup.
Okay. And then, do you recommend that outpatient PCPs offer preventive pharmaceuticals? And if so, which would be appropriate and which would warrant a referral to neurology?
So I think the goal of headache specialists in general, just to give you a little bit of the numbers, you have about 40 pediatric headache specialists in the US. You have about 600 total with a population of 47 million people living with just migraine. And that doesn't even cross into all those other headache diseases that are not sitting in the primary care space for people to take care of. So I think what people would like to see happen is that primary care as a group feels comfortable initiating good care of migraine. So they understand that idea of teaching about the disease and doing lifestyle, know how to work on acute treatment and how to help people meet acute treatment goals, and are comfortable with at least one preventive and how that should be used. Put it on if you get benefit, take it away. And then if those things are failing, it may be that you have someone who has rare attacks, but you can't find anything that works to treat them. Involve the headache specialist. You may have someone who you've tried a preventive and they're failing, then involve the headache specialist. But the idea is hopefully 4% of the population has chronic migraine, right? So it's still a huge number. So really preserving your headache specialist to care for that very refractory group, because even with that, there's still a shortage of people to take care of that percentage of the population.
All right, good to know. Okay, if anyone has any other questions, please feel free to go ahead and either raise your hand or unmute to ask your question. I'm gonna go ahead and go through the rest of my announcements, but if you raise your hand or unmute, I will see that and stop talking for you to ask your question. Okay. Um, one thing you need to know very specifically is that you need to take the evaluation to claim your credit. I don't have enough information about you to give you credit for this activity until you take the evaluation. It typically takes less than 2 minutes, and you can find the link in the chat and also scan this QR code to get to the evaluation form. Even if you're not planning to get credit, AMA PRA credit, it still helps us to improve our education offerings. So please go ahead and do that. Next up, our upcoming conference in August, it will be in Alexandria, Louisiana. We're excited to have Dr. Maria Trent, past president of the Society of Adolescent Health and Medicine, joining us on Friday, August 16th for the first concurrent session talking about changing bodies, adolescent health in context, adolescent sexual health in context. We will also be joined by American Academy of Pediatrics President-elect Dr. Sue Cressley, who will be presenting Harnessing Your Pediatric Power to Shape the Future. The link to that is in the chat. Our next webinar in this series will be on June 13th, 2024 with Dr. Ann Troy, entitled Implicit Bias and Affirming Care with LGBTQ Patients. And you can register the same place you registered for this, pediatricgumbeaux.eventbrite.com. And finally, all of the on-demand education, including all of recordings of previous webinars, are available on our education page and on our YouTube channel. And this is the link to our YouTube channel. The recording of this will be up in about 1 week. And immediately after this, I will send you the link to the evaluation as well as other links shared. And I will also send the link to the AHS First Contact site so that you can see the slides that were used. Okay, Dr. Gautreaux, anything else that we need to cover?
No, I think that's it. I just want to thank you for sending out that link. That's actually a great idea. We
Yes,
appreciate it.
no problem. And thank you so much for coming and joining us today. And thank you everyone for being such a great audience. This is officially the biggest audience for a webinar to date, so I'm very excited. Okay, I'm going to go ahead and close up for the day. Have a great day, everyone.